So I'm going to now talk about things you may not have known about lipedema and Dercum's disease. So here are my disclosures. So I did a chart review of all of my patients. I do an extensive physical exam on my patients because I just feel like we don't really know a lot about these diseases, so you might as well examine every nook and cranny, and if you've come to see me, you know. I also handed out a questionnaire called the ACEs questionnaire, and this is looking at childhood trauma, trying to see if childhood trauma had any effect on my patients, and especially those with lipedema. And so if that's a trigger for you, when this happens, plug your ears, close your eyes, have someone tap you on the shoulder. If you're streaming it, you can just turn off the sound. And then I did bioimpedance spectroscopy using the SOZO device from ImpediMed. So we all know that the stages of lipedema don't completely accurately describe what women with lipedema look at, so I'm experimenting. And actually, I went and visited Tom Wright in his clinic, and we both agreed on half stages, which is really bizarre, but we're kind of like Bobbsey twins. So what you heard from Polly what the 3 stages are. So I used a half stage between 1 and 2, so 1.5, and that's where you have a mattress pattern on the lower part of the leg, but not the upper. And then 2.5, you have protrusions of tissue that are not completely lobules like you see in stage 3. And this is an example of like a half lobule. So if you look at the top, you don't really see much on her hip, but when you look from above, you can see that there is a lobule that's starting to form, and I called that 2.5. Whether these are ever going to be standard or accurate, but I'm going to show you some data that suggests that they're pretty good. So after I'd stage all of my patients, I looked at their body mass index, and I think you can see that as you go up in stage, the body mass index rises very nicely. And when I plotted this out in a different way, you can see there's a beautiful correlation between the stages and body mass index. Not that body mass index explains lipedema, it doesn't, it's just a tool. And then I asked women, what was the highest weight you ever had? That you were ever at, and I asked lowest weight too, and I'm only going to show highest weight. And you can see that if we just look at your standard stages, that the highest body weight that a woman ever had correlates very nicely with the stages. Okay, why is that? Well, we know that about 40% of body mass index is inherited. So you get 20% of your body mass index from your mother and 20% from your father. And this was done looking at 100,000 children in 6 countries. So my question is, can parental BMI help predict which women with lipedema are at risk for advancing to higher stages? So you heard from the Lipedema Foundation at the opening ceremonies that we need to go back in the history and ask, like, who has lipedema in the family? And I completely agree with that, but I also think you need to ask who has a high BMI in the family as well. Because if you've developed lipedema early on and there's a lot of high BMIs in your family, we ought to get really serious about keeping your weight as stable as possible to prevent you from progressing. And then I asked women, what are your typical symptoms of lipedema? Do you bruise easily? Do you swell? Do you have pain? And I did it by half stages. And you can see over 90% of women with lipedema do bruise easy. They do swell. They do have pain. But look at that. Look at those women with stage 1 lipedema. About 30% did not have pain. And this is not, I'm not like pushing on them and twisting them like I did yesterday in the physical exams with the Lipedema Foundation. But if we plot that a different way, look at that. Women with early stage lipedema don't have maybe as much pain as women in later stages. So my question is pain an absolute criteria for lipedema? And I think you definitely want to have pain and dysmobility so you can get liposuction. But I think we also need to realize that you don't have to have every single symptom. You might have fat that's different that you can't lose by diet or exercise, but you don't have to have pain to know that you're different. So this is a complicated slide, but I think it's really important. So I asked them what body parts swell, what body parts are heavy, what body parts have pain. And so you can see the arms are in reddy orange, the abdomen is gray, the lower back is yellow, the thighs are in green, and the calves and ankles are in purple. And I think what you can notice on the swelling is that when I draw a line at 50% and we look at the women with lipedema, we look at symptoms that have to affect more than 50% of the women. Because if they affect less than 50%, maybe it's not as important. And you can see that only the calves and ankles swell in over 50% of women with lipedema. When we look at heaviness, you can see again that the ankles and the calves are affected, but look at the upper arms are now heavy, although they don't swell. The abdomen is heavy, but it doesn't swell. And the thighs now are really heavy. And we saw that yesterday during the physical exams. And then in terms of pain, you can see that the upper arms have pain. The abdomen does not have pain. So the abdomen is very heavy. We can feel that it has nodules, but it doesn't have any pain. And I think that makes this a confusing area of the body, because the Europeans don't think the abdomen is affected in lipedema. But we in the US think that that is a good possibility, and that lipedema is a more systemic disease. And then you can see that the lower back has pain. One of the things that we did not examine in our physical exams yesterday and the day before with the Lipedema Foundation was the back. We ignored the back completely. But if women with lipedema have a lot of low back pain, why are we ignoring that, and what does that mean? So I think that that is important, something that we should be focusing on. So this is just plotting it a different way, just looking at the lower legs, pain, swelling, and heaviness. When you look at the research studies for lipedema, and I'm one of those researchers, and I don't know where Sarah is, I can't see very well, but Sarah and I picked the thigh and the abdomen to do biopsies on, but look at the lower leg. That's something that we're not even looking at. And it's harder to do a biopsy on that lower leg because it's so thick. And that's because the fascia is particularly thick on the calf. And you're going to hear more about fascia from Linda Ann Kahn. And this fascia divides the legs into different compartments, and it acts as like kind of an exoskeleton to hold that calf tightly together. Why is that? Because you've got muscles in the calf that need to pump the venous and lymphatic fluid from the foot all the way up to the heart. So that fascia has to be really thick. So my question is, does this swelling and heaviness and pain in the calf indicate a breakdown of the fascia? You see, I'm putting it all on you. I don't have all the answers. So now I'm going to talk about body water. So this is something that you might expect, that as the stage of lipedema increases, so does the total body water, right? So women with stage 3 have more body water than women with stage 1. Okay, now let's look at it a different way. Let's divide total body water by weight. Now look at it. Women with lipedema have less total body water for their weight than women with stage 1. Doesn't that kind of like twist your brain a little bit? So the reason is because women with stage 3 have more adipose tissue, and adipose tissue holds less water. So let's look at body composition, and I really simplified this. So we're looking only at fat mass, fat-free mass, which is muscle and bone, and total body water, which includes intracellular fluid and extracellular fluid. And look at that. As you go up in stage, the yellow increases, so fat increases, and then the percent of muscle is lower, and the percent of total body water is lower. And what's really interesting is this fat isn't just on the outside of the body, right? It intercalates in and around muscle. It can go into the liver. It can be in many places in the body. And that means there's less hydration in those areas. And in order to get lipolysis, it's important to be very well hydrated. And you need to move the fluid around in the body. And how do you do that? You exercise, you wear compression garments, you use pumps. And why does swimming work so well? Because you're really moving the fluid deeply, and you're moving that fluid around, and you're hydrating. And so you get out of the pool and you pee because you've moved fluid around, and what should you immediately do? Hydrate. So let's look at body water in the legs. So as in the right leg, pink, or the left leg, blue, as you increase in stage, you increase the amount of fluid in the leg. Okay, well, we know that if we divided it by the weight of the leg, it would be in the opposite direction, but I don't think that's what's important. What I think is important is what is the risk of lymphedema? So you're looking at the right leg on the left and the left leg on the right. I did that wrong. Pink is right, blue is left. So the SOZO bioimpedance spectroscopy gives you a risk measure of lymphedema. So when you look at the yellow boxes, that is normal. You can see that in the right leg, for women with stage 1, no risk of lymphedema on the right leg. There's some women with stage 2 that had an increased risk for lymphedema, and then look at women with stage 3, that right leg, much higher risk of developing lymphedema, or more women were at risk. Now let's look at the left leg. Do you see the little blue dot rising above the yellow square? There are some women with stage 1 lipedema who have an increased risk of developing lymphedema in the left leg. So the legs are kind of different, and I would love to hear from the vascular folks, why that is. And then you can see the women with stage 2 and stage 3, many more are at risk for lymphedema of the left leg. And during the physical exams, when we talk to women, a lot of them say, well, my left leg is always worse than my right leg. Now, there are some women whose right leg is worse than their left leg, and they may have venous disease in that leg or more venous disease in the left leg, but we're not sure. But I find this to be fascinating, that we are not as symmetric as we think we are. So when we look at the arms, though, look at that. No difference. Body water the same, no matter what stage. I even split it into half stages trying to find something, and I couldn't. So then I looked at what's called the phase angle. And that phase angle is a difficult concept. And basically, what the phase angle is how electricity passes through your body. And it is an indicator of how healthy your cells are. And there's a young lady in the audience who taught me more about this than I knew, and her name's Denise Morrow, and you'll hear her talking later this afternoon. But it also measures how hydrated you are, and it also is a useful marker to detect inflammation, right, without cutting into your body. And so you can see we're looking at the arms here, and the phase angle is normal in the right arm, it's normal in the left arm. Now let's look at the leg. Women with stage 3 lipedema have a lower phase angle. Lower is not good. So we saw that women with lipedema women with stage 3 lipedema were at greater risk for lymphedema. Maybe this phase angle is also a marker of greater inflammation in the left leg and the right leg in women with stage 3. So then I still think that lipedema is a systemic disease, and so I looked at the torso. So I had to actually derive this value. So I took total body water, and I subtracted the water in the 4 limbs, and then I said, what's left? Oh, the torso. So is there an increase in torso water with stage? And sure enough, look at that. Beautifully different among even the half stages. So I do think that the torso in women with lipedema is affected, and that women with lipedema hold more water in their torso as the stages increase. So the question then is, does lipedema just affect the limbs? And when I examine women with lipedema, I look in the supraclavicular area here. And this is where the lymphatics dump into the great veins. So you're bringing lymph up from the body, and you're dumping it in up here. And even yesterday, some of the women pointed out, look at this here. And it's a little bit maybe fluid, it's a little bit fat, it's a little bit inflamed fascia and connective tissue. So when I examined women, I found that 42% of women with lipedema had increased supraclavicular tissue. And I think that's because the lymphatic system is a little bit slower, And so fluid's gonna accumulate in areas like around lymph nodes, especially here on the medial elbow, but also where the lymphatics dump into the greater veins, so up here as well. So I think that's a marker of a slow lymphatic system. So now we're gonna look at, compare the right and left arms and the right and left legs. So even though I showed you that amongst the stages, the right arms were all the same and the left arms were all the same, but when we combine them together, the left leg has less water than the right leg in all stages. That's weird, right? So then I decided, well, let's divide it into intracellular water and extracellular water and take a look at that. And intracellular water is water in the cells, extracellular water is water in that interstitial organ, that interstitial space. It's in blood plasma and it's also in lymph. A marker of chronic disease is a low intracellular fluid over extracellular fluid. You want more intracellular fluid. You want that number on the top to be higher. But if that value is less than 1, that's a marker of chronic disease. So let's look at the right arm in stages, and you can see that really there's no difference between the intracellular fluid over extracellular fluid for the right arm or the left arm. But when I compare the right arm to the left arm directly, you can see that the left arm has a greater marker of chronic disease. So that was kind of weird because the arms have not been different up to this point, but what does that mean? So before I tell you, let's look at the legs. Look at the right leg, no difference among stages. Look at the left leg. Women with stage 3 lipedema have a marker of chronic disease in their left leg. And when we compare them directly, you can see that the left leg is lower than the right leg for all stages. So now we have, let's go back. Now we know that the left arm is lower than the right arm, and the left leg is lower than the right leg. All right, so let's look at the body. One thing I noticed on the body was that the heart is on the left side, right? The heart holds a lot of fluid. That's extracellular fluid. So I think the left arm has lower fluid than the right arm because the heart's on the left side. And I've actually talked to Lymphedema about this, and they agree. So I think the arms actually are okay. We can explain that. But I can't explain the legs. And I think the fact that the left leg is lower in stage 3 than stage 1 or stage 2 means there's something going on in women with stage 3 lipedema in their legs. It could be that there's something going on in the pelvis. So how often do we look at pelvic vessels in women with lipedema? Not very often. And where do women carry a lot of their weight? Around the pelvic area, the buttocks, the hips, right, the thighs. So maybe there's something going on in the vasculature of the pelvis that we need to look at. Maybe there's a little bit of May-Turner's where the left common iliac artery crosses the left common iliac vein, and it presses it so that more fluid accumulates on the left. This is all stuff that we need to look into, and it's really up to our vascular colleagues to do that. So lipedema muscles. I didn't see Patty Cornute, but I always think of her when I think of muscles. And I plotted fat mass versus skeletal muscle mass. And you can see that as fat mass increases in each stage, muscle mass goes up. That's a good thing because muscle eats fat. And there was a significant increase in muscle mass, especially in women with stage 3. So that's really hopeful. And then I plotted what's called skeletal muscle index, and that is your skeletal muscle mass over your height. And you can see that even in half stages, that skeletal muscle mass index increases beautifully, and it's very nicely correlates with stage. So I think that's hopeful, and that means that you can still build muscle, hydrate enough to break down that lipedema fat. We just have to better understand that connection. So now I'm going to talk about hypermobile joints. So there's 3 publications out that say that about 60% of women with lipedema have hypermobile joints. That means your connective tissue is different. Polly mentioned that this morning, a loose connective tissue. So I looked at the 3 stages and said, how many women have hypermobile joints? And I think we're up to about 75% now, which is very high. And my friend Jose Luis Simaro in Madrid says it's about 80 for him. So here's the potential trigger. Plug your ears, close your eyes. I'm going to talk about trauma and lipedema. And I use the ACEs questionnaire, and it has 10 traumatic events that could have happened to you in childhood. And the likelihood of a negative effect on your life increases with the number of traumatic events that you were exposed to. And what I did was I compared women with lipedema to a control published population. So the control is black, lipedema is red. And you can see that there are fewer women than controls who experience no trauma. And if you look at 1 traumatic event, 2 to 3 traumatic events, or greater or equal to 4 traumatic events, women with lipedema have experienced more trauma in their life. And I obviously need to compare this to other controls, and it would be nice to have my own control population, which I don't have. And I also don't think the ACEs questionnaire really represents the trauma that women with lipedema experience, because when you have unusual fat on your body and you look at other kids and you see that you're different, that's a trauma, and that's not included in this questionnaire. So I think we need to recreate a trauma questionnaire for women with lipedema to better understand it. And I asked them, did these adverse childhood experiences affect your health? And you can see that it's not 100%, but even if 40% of women have some effect on their life, and almost 20% have a lot of effect on their life, we should be supporting women with lipedema a little bit more and asking more questions. And I think one of the most important reasons why is because childhood trauma experience increases inflammation. And we know that inflammation worsens lipedema. And you're going to hear from Tammy Ferris, and she's going to talk about her experience. And one of the things that she noticed is if she decreased her stress, she felt better. And one of the other interesting things about this paper is they looked at 3 markers of inflammation: C-reactive protein, which is something I measure all the time, but they also looked at IL-6 and TNF-alpha. And CRP did not help at all with finding the inflammation associated with trauma, but IL-6 did and TNF-alpha. And maybe we should be looking at different inflammatory markers clinically in women with lipedema than just C-reactive protein. All right, connective tissue on the lower limbs. So during the exam yesterday and the day before, one of the things that we looked at is, does fat cover the shin completely? Does fat cover the knee completely? And you can see even in the early stages that there's a lot of fat on that shin. So again, the calf is very important in lipedema. And then as lipedema progresses, I think fat's moving up the leg and starts to cover that knee. And so in later stages, the knee is completely, absolutely covered by fat. And I think that is a very easy marker for a clinician in a busy practice to check. Is there fat covering the shin? Is there fat covering the knee? Done. We got to get our healthcare providers touching patients again and not just putting the stethoscope on. I also looked at fat on the ankle, so around the lateral ankle bone or lateral malleoli, the medial malleoli, and around the Achilles. And you can see that as stage increases, so does fat around the ankle. And you kind of knew that. You know the cuff, right? But I think it's important not just to call it a cuff, but to look exactly where that fat is, because different veins originate from those locations. And so if you have a vein issue and fluid is being pushed down onto the ankle, you kind of need to know which vein that is. And then we didn't see a lot of fat around the Achilles tendon until stage 3, at least in this study. And another interesting thing about lipedema is we say hands and feet are not affected. And what we mean by that is hands and feet are not affected by lymphedema, L-Y-M-P-H. And that's to help distinguish lipedema from lymphedema. And that's complicated. But I reported a number of years ago that about 30% of women do have fat on the hands, and I was blown away yesterday by how many women with lipedema have fat on their hands. And you can see that looking here for fat on the feet, that women with stage 3 are more likely to have fat on the feet than women with stage 1 or stage 2. So something, there's something's happening to the connective tissue. It's loosening, fluid's getting in there, fat is growing, despite the fact that stemmer sign is completely negative. Venous disease and lipedema. So I really think that venous disease plays a large role in lipedema. Many women have spider veins. Many women have visible varicose veins, at least by thermography, which is shown there on the right. You can see that snaky yellow vessel there. But they don't have corona phlebiticata, which is a marker of chronic venous disease. So there's something different about venous disease in women. And then I considered different diagnoses in women. Like I say, I think you might have mast cell disease. I think you might have Dercum's disease. I think you might have venous insufficiency. And you can see those numbers there. And what I want to point out is that about 55% of women may have mast cell activation syndrome, at least in my guesstimation. And when we looked at how many women with lipedema had allergies, about 60% of them had allergies, which correlates pretty nicely with that. And what's interesting, Linda Ann Kahn, is that there are mast cells in the fascia, right? And so could inflammation from mast cells in the fascia be causing a breakdown? And remember I said maybe there's a breakdown in the fascia, in the calf. Could mast cells be playing a role? So finally, I'm going to finish with Dercum's disease. And remember, we looked at the risk of lymphedema in women with lipedema. I also looked at the risk of lymphedema in patients who had Dercum's disease. And look at that, no risk. No risk, despite Dercum's disease being a very inflammatory disease. And we know that inflammation slows lymphatic pumping. Why are patients with Dercum's disease not at risk for developing lymphedema? That's a big question. I don't have the answer, but I find it to be absolutely fascinating. I also use my thermal camera to look at patients with Dercum's disease, and this is a woman who has angiolipomatosis. And normally you should see just I probably should have shown that, just a normal photo would be just homogeneous orange. And you can see, like on the edge there on the left, you can see it's just nice and orange. But look at all of the little snaky yellow marks there. Those are all vessels, right? Easy to see, very dramatic. So could we use thermal imaging to possibly diagnose Dercum's disease? And that would be, you don't even have to touch the patient. We can tell providers, hey, you still don't have to touch them. You just have to look at them with the thermal camera. And then this is a young woman who had a motor vehicle accident. And I mentioned early in my last talk that trauma can induce the development of Dercum's disease. So she had her seatbelt on, and she was hit from behind, and that seatbelt locked, and she got severe pain in her chest. And you can see the multiple vessels on her chest by thermography. So again, I don't think it's just angiolipomatosis that we can find, but it's also other areas of Dercum's disease that we can find with a thermal camera. So my concluding remarks. Does swelling in the calf indicate a breakdown in the fascia? I think that we really need to start looking at the fascia, and I'm glad that there's some conversations and talks about it here. Is pain in lipedema fascia in origin? Fascia has more pain receptors than muscle, so maybe it is. Is lipedema systemic disease? We're now finding connective tissue changes on the feet, ankles, calves, knees, thighs, abdomen, lower back, and supraclavicular. You can't tell me that's not a systemic disease. And also, could it be because hypermobile joints change the connective tissue, causing leakiness in the lymphatics and in small blood vessels and the veins, and that damages the fascia, in addition to the fascia having changes itself? I think we need to ask about lipedema in the family, but also body mass index. We need to look more into vein disease. We need to look to see if inflammation is secondary to mast cell issues. We need to ask about a history of trauma that may have increased inflammation and look at different markers. I just think we need a lot more work on the immune system in lipedema. And for Dercum's disease, is angiogenesis a marker of Dercum's disease? Can thermography be useful in identifying it? And why is there less of a risk of lymphedema in Dercum's disease when it is a high inflammation disease and inflammation slows lymphatic pumping? Thank you.